Hello, my name is Asra Mohammadi and I'm a senior at Middlebury College where I study economics and global health. In light of current events, this interview today is a part of a series of careers in public health and part of the MIDDVantage program. It is my pleasure to introduce you all to Mikail Dastgir, a Middlebury alum class of 2010. A graduate of the United World College of Southern Africa, UWC-SA, Mikail attended Middlebury as a UWC Davis Scholar, graduating in 2010 with a major in international politics and economics and a minor in African studies. During his time at Middlebury, Mikail pursued summer internships in the nonprofit sector in Dar es Salaam, Tanzania, and as an independent researcher with the AIDS and Society Research Unit at the University of Cape Town. After graduating, he went on to be selected for the two-year junior professionals program with the World Bank Group based in Washington, D.C., working with the urban and water and health and nutrition and population departments for the sub-Saharan Africa region, thereby continuing to cultivate his interest and knowledge of the global public health field. Between 2012 and 2014, he attended Harvard University School of Public Health, graduating with a Master's of Science in Global Health and Population, concentrating in infectious disease, epidemiology, and maternal and child health. He subsequently returned to the World Bank as a health specialist in 2014, managing the bank's health sector portfolio in Southern Africa and South Asia. Currently, the areas of focus of the healthcare programs under his purview include health system strengthening, maternal and child health, HIV, TB and malaria mitigation, and the healthcare of internationally displaced populations in Bangladesh and Pakistan. I'd just love to know more about your day-to-day, what the World Bank does in general, and what that entails.
Well, the World Bank's obviously, as you mentioned, it's a massive organization, and we have both we have research divisions, and that's what produces all of the data that students are most familiar with, the World Development Indicators, etc. And the Developmental Economic Research Group tends to focus on those areas, studies and macroeconomic data. And then you have the different practice groups, what we call them, that actually implement programs. They're also generating knowledge at the country level, at the project level, or operational research, that's what we call. And so those operational groups are divided into your different content areas. You have health, nutrition, population, which is where I work. Then you have the education group, the energy sector, infrastructure, that's responsible for big infrastructure projects, roads, bridges. Energy is responsible for building infrastructure related to energy, etc. So in the health, nutrition, population group, we're divided into different regions. So I work in the Africa region, which is it's divided into three teams, the one by region within the continent. So we have East and Southern Africa where I work, then you have Central Africa, and then you have West Africa. Similarly, we have South Asia group, Eastern Europe, Central Asia group, Latin America, etc. And because we're an umbrella of the health and population group, we're encouraged to work out of our different regions on various projects, but to varying degrees. That doesn't always happen. We tend to work, a lot of the time we do work within our regions, and we interact with other project managers that work on different countries within our region. So the projects that I mentioned earlier that I've kind of been under my purview have been maternal and child health related projects and HIV/AIDS related programs. And a lot of other partners such as PEPFAR, etc., do work a lot in HIV/AIDS. So I think the main, the World Bank tends to work, we try our best to work with partners and try to do gap filling. We use a gap filling approach, which essentially means that we don't want to be repetitive of what other agencies are doing. So if HIV/AIDS is a major funded area, so aspects that other organizations such as the Global Fund and PEPFAR are funding, we try to sort of work in areas that maybe vertical programs, what we call vertical programs, which focus on a specific issue, don't necessarily cover. So that's why health system strengthening, the overall strengthening of service delivery within the within a country's particular healthcare system. And maternal child health was an area that my mentor tended to focus on quite a bit, because again, not a lot of agencies are focused heavily on it, and we try to. It's something my mentor was passionate about. So improving maternal and child mortality, strengthening the service delivery systems so that immunization programs function well, supply chains and drugs and vaccinations that are delivered to different parts of the health system are reach in a timely manner and are unexpired, are stored in cold storage. There's refrigerators present, and there's reliable energy supplies for the refrigerators to actually work and store these medications that need to be vaccinated. These are areas kind of I've worked heavily on. And overall, obviously, as I mentioned, health systems strengthening, which essentially means how do we improve overall service delivery, whether it's deployment of human resources to all parts of the health system where it's most needed. Supply as well as deployment is key. And then, of course, the aspects of service delivery of within the healthcare system itself. Is there adequate drug availability, equipment availability, infrastructure availability? Is there adequate knowledge of the providers? Are they able to correctly diagnose and then eventually treat the conditions that arrive at their designated level or tier of healthcare service delivery? And if not, how do we promote capacity building to ensure that these doctors and nurses are able to treat? And even if they are able to treat, then the next level is whether the supplies that they need are actually available to them to be able to treat those conditions. An example I'll give is a doctor might say they are able to perform cesarean sections if they need to in a complicated situation, but then if they don't have the anesthesia available, if they don't have a functioning operating theater, then it's very well and good that they're technically trained to be able to perform a service, but then if it's not there's not effective coverage and there's not a delivery of that service is not taking place empirically or practically, then that it's as good as not having the service available at all. So those are areas that I've been working on. And one memorable project that I would say I've really more recently enjoyed working on has been working with the displaced Rohingya community here in Bangladesh, where I'm currently based in the context of the current crisis and not having been able to travel. So I'm here, but it's been interesting to work on this project. Number one, because it is my own country, but I haven't directly worked here since I left for United World College when I was 15, 16 years old. And this has been a very current crisis for the region and for Bangladesh in particular. And it's been interesting to see the conditions in the camps, but also be able to give back in a way to a crisis that's very current within the context of Bangladesh. And what we've been trying to do through that program, which has been interesting for me, is there's been a lot of money going towards helping, obviously, the community itself. But as a whole, the district of Cox's Bazar, where they reside currently, hasn't seen the same level of resources as this particular community has been seeing because of the different partners that are working in the region. So that's where, again, this gap filling approach, where the World Bank, we have our project that is geared towards the Rohingya community, but then we thought in addition to that, let us also design a program that's helping to bolster the health system of the district as a whole. And this will impact not just the displaced communities, but also the healthcare needs of the host communities, because it's a district that has, generally speaking, lagged behind the rest of the country in terms of its healthcare indicators. even before this crisis began. But now there's been all this attention on the district, but it's been focused primarily on this community. So how do we sort of ameliorate that by trying to focus on the overall health system of the district, whether it involves renovating and rehabilitating health centers and the hospitals, providing more human resources, more training for human resources, etc., so that they can deliver healthcare not just to the Rohingya community, but also to the overall population of that district. So that's been a really interesting project currently that I've been supporting.
Speaking of the hot topic, the pandemic, I would just love to get a public health person who's working in public health, their opinion on it. Specifically, if you could highlight how you envision it playing out in the developing world. That is an area of personal interest for me, and I'm sure people would love to hear your views.
It's interesting. I mean, we are, I'm sure you've seen in the news that many organizations, the World Bank included, has diverted resources, financial resources towards fighting this pandemic, particularly obviously in the developing setting. And we are kind of trying to right now evolve our programming to sort of incorporate these areas, whether it involves emergency projects that we fast track approval so that we can begin implementing right away, or as I was mentioning, how we can sort of within the purview of existing programs which are left relatively broad, if we can divert resources from our existing projects towards fighting this particular crisis in the context of developing countries. Pandemic preparedness and emergency surveillance, these are areas that really need to be bolstered during this time so that you can very easily track where outbreaks are breaking out as and when they happen and trace contacts. So it's been interesting for me to observe this from the lens of somebody who is a healthcare professional and to see how developed countries and now developing countries are trying to handle this crisis. Because as you know, this originated from China, which is an industrialized country, and then it's spread to the developed world, and now it's emerging in a big way in developing countries. And one of the interesting things has been observing whether developing countries and healthcare ministries of health within developing countries, leadership in developing countries have been learning from the experiences of developed countries who have all the capacity and resources at their disposal, supposedly, to handle a crisis such as this, and what lessons are being learned. And it's been sad to see that, countries, whether there are capacity constraints in countries like Bangladesh and in sub-Saharan Africa, it's still sad to see that certain steps weren't taken early enough to ensure that this could have been contained to as best as was possible given resource constraints in the developing world. Because we've seen countries such as in Italy and in Europe at large, what their experience has been. And now, 2-3 weeks ago, Italy was at the peak of their epidemic, Spain and Italy, France, and now it's sort of the epicenter has moved to the US. And you have this disparity between countries that have universal health coverage in Europe versus countries like the US, where you have the largest economy in the world, but lacking universal health coverage. And what that essentially means is not everybody who is affected by this disease, by this virus, is able to access healthcare within a country like the US, versus in Europe, where theoretically you have nationalized universal systems where everybody can access it if they need to, but obviously the discourse around it was trying to flatten the curve, as you must have, that terminology has been floating around everywhere, where essentially we're trying to help the health system to be able to cope. And just because everybody has access to healthcare doesn't mean the health system is capable of supporting the healthcare needs of every single individual at one given point in time. It's not designed that way. And so when you come to resource constrained settings, like in developing countries, it's even more alarming, and it's to see, how this epidemic is going to play out, because it's only just now starting to evolve within the context of developing countries. Because initially it had spread within, the Western Hemisphere, and now we're seeing cases in countries like South Africa, in India, in Pakistan, Bangladesh, but these countries were observing the experiences of countries such as Italy and the US, and certain steps, even within resource-constrained settings, might have been taken. And the simplest one could have been, stopping flights and trying to contain the people that were arriving from overseas, including your own citizens, making sure that quarantining was adhered to. If it's not possible, again, we live in resource-constrained settings where individuals live in, 5 people to a small dwelling, and it's not possible to self-isolate if one person has been exposed from the remaining family members. So there should have been certain institutional quarantining measures in place in certain developing countries, so that if home quarantining isn't feasible in certain low-income housing, then you have an alternative available. But these were not as strictly enforced. I'm speaking in this context of Bangladesh as maybe it should have been. People were arriving and they were asked to home quarantine, but they're living in situations where it's not possible. But the facilities for institutional quarantining were not sufficiently available for the people that were returning. And in particular, we have a huge diaspora of Bangladeshis living in Italy, and they were returning in their droves when this pandemic began. And the arriving passengers were not institutionally quarantined. Some of them were, and then a lot of them refused to remain in institutional quarantine. Perhaps the facilities were not adequate for them, or perhaps they didn't have the knowledge and they didn't understand why they were being asked to live in an institutional facility instead of going home. And then it started to spread. And now we have a situation where, in the first few weeks of the epidemic, again, testing has been key in the developed world as well as now in the developing world. And every single country didn't have sufficient testing to really understand the scale of the epidemic in their specific context. And one country that I've really admired and how their approach has kind of been to dealing with this epidemic has been South Korea, because seeing this experience of China, they very early on began ramping up their testing capacity to be able to really understand what they were dealing with in terms of diagnosis, and then being able to target who they were treating. And in a context of developing countries, this has not been necessarily possible. The test for coronavirus, the COVID-19 virus, is a resource-heavy test. It requires specialized PCR equipment. And in the context of Bangladesh, in the very early stages, there was only one center for epidemiology in the entire country that was testing, and they only had a capacity to test a certain number of cases every day. But now, in the course of the last month, they've deployed equipment to different parts of the country, and now you're seeing testing figures ramping up, within 300 to 400 daily new infections every day. But this doesn't mean this wasn't present some weeks ago. It's just that we didn't have the capacity to test. So these are constraints that are very concerning for the developing country context, that and the capacity to be able to quarantine institutionally in resource-constrained environments where people aren't able to self-quarantine at home in the same way. And of course, you have the situation of people's livelihoods being affected. So many people subsist in developing countries in order to survive. And you have situations where people aren't able to earn their daily incomes through selling their wares or peddling rickshaws or whatever examples you might want to give. And whether they're less concerned about coronavirus as they are about feeding their families. And the quote that I've been hearing on the news every day is, well, coronavirus won't kill us before hunger does. And that's something that definitely needs to be dealt with in the developing country context. I know countries are trying to distribute rice, lentils, oil, basic necessities. But again, these are corrupt processes, and wares are being stolen before they're reaching the beneficiaries they're meant to be reaching. And that's really been very sad to see this sort of situation playing out you would hope that in a crisis such as this, humanity would come together to help, the people that aren't able to help themselves. But even in these situations, you have people trying to take advantage of the crisis to sort of amass resources, amass grain, food kind, and all these type of amenities that are meant to help people in general. And that's been very sad to see as well, I would say.
What do you think a perfect response would look like from this day forward if you could direct it and had all the resources at your disposal?
Can you repeat the question?
Yeah. So what do you envision a perfect response looking like if it goes from the developing to the developed world? But let's just say you could direct it right now and had all the resources you wanted at your disposal.
That's I don't feel even that I don't feel prepared, or sort of, who am I to be able to answer a question like that as just a health mid-career healthcare professional, but I'll try. I mean, I think the first thing that's really important in dealing with this epidemic is diagnosis and testing, and we've been hearing it every day from Anthony Fauci and all different levels of healthcare administration, that testing is key. And because this virus is so difficult to test in terms of the resources that are available, it does make it more challenging in the developing country context, not having the specialized equipment to test. But it's still highly, highly important, because you won't ever understand the full scale of an epidemic if you're not able to test. And yes, we have the viral test, which is through this PCR machines, and it's resource heavy, but there are other alternative tests emerging that are not as sensitive or specific as the viral test should be, but they're still a very good alternative, I feel, for resource constrained settings. And these are these antibody testing kits that are also now being used in the US and developed countries to test healthcare professionals. And what it essentially does is, rather than test for the virus, it tests for the presence of the antibody to the virus. And it's not a perfect system, I understand that, and I'm not a scientist, so I can't speak to the intricacies of it, but essentially you will have an antibody in your blood if you were exposed at a given time, even if you're not positive for the virus currently. So there will be an increase in false negatives as a result of testing using this method, but I still feel that as an overall approach, false negatives are not as alarming a problem as false positives, or not testing sufficient numbers of people. So this is, I feel, one aspect that developing countries could be ramping up by manufacturing these relatively low-cost testing kits. I know in Bangladesh they've manufactured an alternative that's meant to cost around $3. These testing kits where all you require is a prick of blood, and then you can test for the antibody to coronavirus. And while it's not ideal, it's still it's a very effective means of gauging at the country level what exactly you're dealing with in terms of diagnosis. That's definitely the first aspect I would have tried to sort of address, is testing. And number two, I would say that given that this virus has been spreading in our globalized community through travel, I think countries should have taken steps very early on to sort of limit travel outside and within international travel into their countries. Yes, there is a moral obligation to bring your own citizens back to your countries from wherever they might be stranded, but in doing so, you also have to have facilities in place to institutionally quarantine people who have not just, it's very difficult because you have people who are symptomatic and and asymptomatic. And if you, ideal circumstances with all the resources available, as you mentioned, I would have quarantined asymptomatic and symptomatic people. But of course, in constrained settings, that's really not practical. So you're only able to quarantine those who are, exhibit certain symptoms at the time. But in bringing people who are stranded overseas into your countries, but you have to have a means of quarantining institutionally those who are most affected or at risk of spreading this virus within their communities and within their families, and also limiting travel from external citizens of other countries into your countries. It's really paramount, and I don't feel that a lot of developing countries didn't take that measure early enough. Maybe they weren't able to foresee how this was going to evolve, between March and April. But I feel that, a country like Bangladesh should have taken this measure much earlier than they did. But they were operating under the assumption that, they had low testing and therefore they had low case numbers, but they were operating under a false pretension that this meant that it wasn't a huge problem in their country. Whereas in fact, as healthcare professionals, that epidemiologists, we know that just because you have low case numbers isn't reflective of what's actually happening on the ground. If you're not even testing of course you're going to have low test numbers if people are not being tested. So that was kind of what's, I think, been a common thread in many countries, that low case numbers tended to lull countries into a false sense of security, that maybe this hadn't reached their borders as yet, when in fact it might have already, and certain decisions were delayed. Lockdowns were delayed, border closures were delayed, when it should have been done maybe in the beginning of March, end of February, even as early as that. But they still were thinking of it as having spread from China to Europe to the US and Canada, but not yet within Sub-Saharan Africa and Latin America and the developing country context. So definitely earlier action, but hindsight, as they say, is always 20/20. So it's easy for someone to make these prescriptions now, but in reality, maybe at the time there were reasons why certain steps weren't taken early enough, particularly in context of the developing world.
My follow-up question to that would be, and it might be a slightly repetitive question, but in terms of how normally when you have outbreaks or diseases, they tend to happen either in the developing world, where we are able to effectively transfer resources from the more developed nations to these developing nations and kind of contain it. But given the sense that everyone is globally struggling, and given Trump's recent decision to cut funding to the UN, how do you envision that particular decision, and the fact that these resource-constrained areas have even less resources now potentially to fight this? How do you envision that playing out or affecting the public health scene?
It's definitely going to be a very challenging time, you're right, because it's a good example would be like, for instance, the Ebola epidemic. It was something that was sort of, yes, there was a huge concern in the West about Ebola, but it was more along the lines of, we don't want it to spread from Sierra Leone, Liberia, Guinea, the DRC to our countries. So we need to develop treatments and make sure it's available so that it doesn't affect us. But it seems something that honestly felt more far removed than coronavirus did, because it was affecting these very low resource settings and countries that aren't very frequently traveled to. So it was easier maybe to contain them, because it's not something that started in a country like China, which is inextricably linked to every single country in the world. And something starting there, it will not take very long for it to spread everywhere else. Whereas if something starts in a country like Sierra Leone, it's more far removed, because you can imagine that there's not going to be as much travel in and out of a country such as that for it to affect the globe. And yes, we have situations now where developed countries are struggling to meet their own domestic healthcare needs, number one. Number two, resources in terms of importing of testing kits, importing of raw materials and reagents to manufacture testing kits. There's going to be, I imagine, bidding wars between countries to import these products like testing products and kits, raw materials to manufacture testing kits. So how do countries, developing countries, compete with countries like the US and the European Union and other countries to import the raw materials they need to manufacture these tests? So yes, it's definitely going to be a very challenging time because every single country, developed and developing, are now going to be struggling with this pandemic. And yes, the recent decision of the US administration to pull funding from the WHO was very disappointing to see. But I've also been seeing within, the press conferences given by Dr. Tedros daily, his daily briefings, that there have been resources that are rallying globally to sort of offset the potential of losing the US funding to the WHO, whether it's through private individuals, whether it's through foundations like the Gates Foundation, and whether it's through other developed countries and the European Union. There are resources being mobilized, and I've seen that within the World Bank context as well, where we've mobilized, I think $190 billion. Last I checked, but don't quote me on the figure, but we have mobilized some resources that are specific for developing countries, and we're not the only organization. There's the UN agencies, and there's other foundations, Gates Foundation, and other organizations that are mobilizing resources for the developing country context. And of course, I think bilateral funding from government to government is definitely going to be affected by this, because you can't expect countries such as the US, as well as European countries that are dealing with the epidemic within their own borders, to have as much resources or make as much resources available for the international needs of developing countries. But I'm hoping that the global community sort of will pull together, and whether it's private individuals and foundations, as well as individual governments, if they're pooling together whatever limited resources are possible, we can sort of deploy them to where it's most needed. And in terms of the public health community, I think there is a lot more kind of opportunities in our field. There are more jobs in this field now because there's such an immense need for it. So I think the jobs wouldn't be there if the resources weren't available to sort of finance the employment of different healthcare professionals in different aspects of responding to this virus. So I think there will be definitely a lot of opportunities in the field, because resources are indeed being mobilized for existing healthcare professionals like ourselves, but as well, there'll be a growing interest in this field, a lot more people pursuing healthcare qualifications, whether it's public health qualifications, whether it's medical qualifications, research qualifications, etc. So there will be, I feel, this has been certainly a wake-up call for the global community in terms of yes, the death rates may not be as high as other epidemics that we've seen in the past, but in terms of its reach and in terms of how it has slowed down an entire global economy, we've certainly not seen anything like it in the lifetime of ourselves, as well as our parents even. And I think the memory of this, I hope, will make people and organizations better prepared in sort of mobilizing financial resources and decision making at all levels of policy, not just from healthcare professionals, but also decision makers within the policy framework of various countries who have an impact on how a healthcare system might be run, but they're not necessarily working directly on healthcare ministries specifically, but hopefully they'll make better decisions and deploy more resources in kind and financial to pandemic preparedness, and two, surveillance systems, and so that in future outbreaks, there's better kind of surveillance systems and measures in place to really pinpoint where an outbreak starts, how it starts, and trace contacts, and then better able to contain it, particularly in resource-constrained settings.
That hits everything that I'd hoped to ask you today. Unless there's any closing remarks on your end.
No, I think all I'd like to say is thank you very much for the opportunity. I hope I haven't rambled too much in my responses, but I am optimistic for the field of public health. I do feel that there's going to be a lot more interest and hopefully more focus and resources diverted to the healthcare sectors in the context of both developed and developing countries, so that there will be opportunities for people to engage and really prevent sort of future outbreaks from taking place. I really hope a country such as the US, with all the resources at its disposal, really takes a strong and hard look at their healthcare system and its imperfections, and really tries to sort of engineer and design a system that's more equitable and more able to serve the needs of its entire population, not just those who have the financial resources to afford healthcare. Because as you've seen in the news, this pandemic has certainly affected minority communities in the US and the UK and Europe much more strongly than it has, other communities. And that's simply a factor of not just access to healthcare, but also the types of essential work that is done by minority communities, whether it's public transport, whether it's delivery of, mail services, Amazon, supermarket jobs. These are all fulfilled by minority communities who do not necessarily have access to adequate healthcare, but they're putting themselves at the highest risk of contracting this. And that's why it's no surprise that the spread of this virus in those communities has been higher. So I hope that countries like the US take a stronger look at their healthcare systems, where they have the resources, but it's not serving the needs of their entire communities. And hopefully something can be done about it within the next year or two, as we kind of learn from this experience.
That hits everything that I'd hoped to ask you today. Unless there's any closing remarks on your end.
No, I think all I'd like to say is thank you very much for the opportunity. I hope I haven't rambled too much in my responses, but I am optimistic for the field of public health. I do feel that there's going to be a lot more interest and hopefully more focus and resources diverted to the healthcare sectors in the context of both developed and developing countries, so that there will be opportunities for people to engage and really prevent sort of future outbreaks from taking place. I really hope a country such as the US, with all the resources at its disposal, really takes a strong and hard look at their healthcare system and its imperfections, and really tries to sort of engineer and design a system that's more equitable and more able to serve the needs of its entire population, not just those who have the financial resources to afford healthcare. Because as you've seen in the news, this pandemic has certainly affected minority communities in the US and the UK and Europe much more strongly than it has, other communities. And that's simply a factor of not just access to healthcare, but also the types of essential work that is done by minority communities, whether it's public transport, whether it's delivery of, mail services, Amazon, supermarket jobs. These are all fulfilled by minority communities who do not necessarily have access to adequate healthcare, but they're putting themselves at the highest risk of contracting this, and that's why it's no surprise that the spread of this virus in those communities has been higher. So I hope that countries like the US take a stronger look at their healthcare systems where they have the resources, but it's not serving the needs of their entire communities. And hopefully something can be done about it within the next year or two, as we kind of learn from this experience.
Thank you, Mikail, for sharing your insights and views with us. We really appreciated that and your time. And
thank you for having me.
it was our pleasure entirely, and thank you to our viewers as well for joining us. Be on the lookout for more episodes of this series.